Hi, welcome back to Educator.com. This is the lesson on the male reproductive system. So if we start with the external genitalia, obviously the penis is a major part of the male external genitals. If we divide it up into a few different parts, the crus is near the base of the penis, and actually if you look at the corpora cavernosa, it's specifically the base of them that's inside of the body cavity. So it's part of the way that the penis is anchored inside the body. And speaking of the word body, the majority of the penis is the body of the penis, which would be all of this region, which of course varies in length. The glans portion of the penis, the glans penis, is also known as the head of the penis, where the urethral opening is going to be found. And of course, through the urethra, you're going to have urine and seminal fluids coming out that contain sperm. The prepuce is also known as the foreskin. So this is the same thing as the word foreskin. In this particular diagram, they don't do a very good job of showing it. I mean, it's not labeled is what I mean. Here it is. So this outer region here and here, of course, this is a cross-section, a sagittal cross-section through the penis, but there's some debate as to whether or not the removal of the foreskin is a good or bad thing. Depending on who you ask, I mean, it is a controversial topic. In certain religions, it's removed right after the baby is born, within a few days. Some men elect to do it later on in life. But advantages of getting it removed is that inside of the region between the surface of the glans penis and the inside of the prepuce, you're going to have a material being secreted called smegma. And it is a kind of substance that is nutrients for bacterial growth. Bacteria would be attracted to that, and you're actually more at risk for certain UTIs, urinary tract infections, and the studies have shown that the foreskin there makes you slightly more at risk for certain viral infections, including HIV. But men who have this particular part intact, as long as they keep it cleaned, they can reduce those problems, of course. One of the disadvantages of getting rid of it, from what I've read, is that there is actually a loss of sensation because you are removing some of the skin associated with the head of the penis or the glans penis, and men who've got it removed after having sex early on in life have reported that there is some reduction in sensation during sexual intercourse. So it's one of those topics that, depending on who you ask, you're going to hear various opinions as to whether or not the removal of that is a good or bad thing. Inside of the body of the penis, you're going to see the corpora cavernosa. So one of them is called corpus cavernosum, but there's two. And you can't see it very well from this particular angle, but you can see it right here. Here's the corpora cavernosa. Corpora cavernosa. There's actually two. It's like two tubes running side by side. And then underneath them, you would see the one corpus spongiosum. So inside of the corpora cavernosa, each one has its own artery, and there's a lot of tissue inside of there that will get engorged with blood. Lowering the blood pressure in that artery is going to get increased blood flow inside of sort of this chamber, and that's what leads to an erection. The corpus spongiosum is underneath it. You can see that right here. Corpus spongiosum. Corpus spongiosum. That's actually, inside of there is where you would see the urethral passageway. And then, of course, there's the scrotum, the sac that holds the testes inside of them. So it's normal to have two testes. Each one is a testis. You also could use the term testicle. But the scrotum, like I mentioned with the female reproductive anatomy lesson, scrotum is analogous to the labia on females. And of course, the testes are analogous to the ovaries. It's normal for the testes to hang outside of the body cavity. And I'll mention more about that in a slide later on in this lesson. It turns out that the inside of the human body, 98.2.6 degrees, whatever it is actually too hot for sperm to develop normally. Speaking of which, the gubernaculum testis. This is a connective tissue fibrous tract that exists in developing embryos or fetuses, and it connects the gonads to the peritoneum. So early on, whether you're a male or female, as you're developing in the womb, the gonads, which are going to either become ovaries or testes, are inside the abdominal cavity. If you're a boy, if you have the XY, of course that equals male, then you're going to have stimulation of those gonads to leave the inside of the body and end up in the scrotal sac. So during the 7th month in utero, it contracts, and the contraction of it is what gets those gonads to descend down this fibrous tract, and they end up in the scrotum. So by the time the baby is born, the gonads are now outside the body cavity in the scrotal sac. Cryptorchidism is failure of the testes to descend. So it's normal if you're female, if you're XX, so no Y chromosome, to have the gonads stay put and become ovaries. But in some babies, in some male babies, the failure of the testes to descend is a problem, because not only is that male going to be infertile if they don't leave the inside of the abdomen, because, like I mentioned in the previous slide, sperm cannot develop in that temperature. They need a slightly lower temperature outside the body cavity to develop normally. But also, if you keep the testes up there, and like, let's say the parents are just, for some reason, okay with the fact that their male child is not going to be able to have kids, if you leave the gonads there, it's more likely that they're going to actually give the person cancer later on, that those tissues staying in the abdomen, they're not supposed to be there normally in a man, and they will end up removing them if they can't get them to descend naturally. So that effectively would make that male sterile. All right, inside the scrotal sac, if we were to look into it, the superficial parts, of course, is the scrotum itself. The scrotum is made up of the skin on the outside. Of course, there's going to be hair associated with that. Dartus muscle, and then scrotal fascia. So the dartus muscle is one of the muscles that has to do with maintaining the testicles or the testes in the right area in terms of getting them the amount of heat they need, or reducing the amount of heat they're exposed to. So normal relaxed tone in a dartus muscle is what makes kind of that wrinkled look of the scrotal sac. And then the scrotal fascia is deep to that muscle, and that's kind of like a sheath around the testes. The scrotum is anterior to the anus and posterior to the base of the penis, in between the penis and the anus. The cremaster muscle is a bit deeper associated with the scrotum, and it contracts during intercourse or in response to decreased temperature in the scrotum. So if a male is in a colder environment, it could be cold water, like in a pool or in the ocean, you're going to get an automatic reaction that causes the scrotum to contract. The muscles inside of it pull the testes up closer to the body cavity, and that's going to warm them. And it all has to do with maintaining sperm health, and you don't want them to die off. Another thing is just stroking the inside of the male thigh actually would stimulate cremaster muscles to contract slightly and raise testicles up closer to the body cavity. The epididymis. The epididymis is a coiled tube inside of the scrotum associated with where sperm are made. And you're going to hear more about the seminiferous tubules where the sperm develop. But this is a coiled tube that holds recently developed spermatozoa. So they kind of hang out there until ejaculation happens, until they're ready to be released into the urethra, inevitably. So the functions of the epididymis, several things. You can adjust fluid composition or amount within this part of the testes. It's also a recycling center for damaged spermatozoa. So if sperm have been made and they get damaged, maybe they were made incorrectly, there's some errors in their structure, they will get broken down, and the parts that are suitable, the macromolecules associated with making a sperm, can be recycled to make new sperm. And of course, it stores and protects spermatozoa and helps facilitate their development until they're ready to be moved on into the vas deferens and inevitably the urethra and out the body. So the anatomy of one testis, that is singular for testes, if we looked at one, here's Gray's Anatomy picture, you can see that there are all these sections here, and they're called lobules. And then they are separated by septa. So you could say septum, 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 lobule. And so these lobules contain a vast branching of seminiferous tubules that end up feeding into the epididymis. But these tubules within the lobules are about 80 centimeters in length. And that's incredible to think about because 80 centimeters, very long. And there's not a lot of space in here. So they are tightly coiled. And of course, this is where sperm are produced in these seminiferous tubules. If you look down one tube, so here's a cross-section through one of these seminiferous tubules in one lobule. Along the edge, you see what are called nurse cells and the stem cells, spermatogonia associated with making sperm. So the spermatogonia undergoes cell divisions to make sperm. And as you go slightly deeper, you eventually get to the lumen, the space within the seminiferous tubules. And these recently made sperm are going to go through the lumen, through these ducts feeding into the epididymis. And the epididymis, here it is right here. And of course, the epididymis connects to a tube called the ductus deferens or vas deferens that would send them to meet up with the rest of semen that's going to be produced. So the septa, like I mentioned earlier, these divide the lobules. Efferent ductule, those are the ducts that get the sperm out of the lobules into the epididymis. And keep in mind that there is an epididymis associated with each of the testes, and there's a vas deferens on each side as well. So here they label it ductus deferens. It's also known as the vas deferens. Spermatogenesis is the making of sperm, analogous to oogenesis in females. So there are three main parts, similar to how it was in females. Mitosis has to happen initially. Mitosis is just that regular cell division maintaining the same chromosome count, making identical copies in the daughter cells. And the mitosis happens with the spermatogonia, and as those cells are made, those cells will eventually go through meiosis to make spermatocytes. And meiosis is where you reduce that chromosome number in half, so you get to that 23 number. 23 in sperm plus 23 in egg equals 46, and making a new diploid number in that zygote, that first cell of life. So spermiogenesis is the last part of it. That's where the products of meiosis, those haploid cells, actually become full-fledged sperm through spermiogenesis. And nurse cells help make that happen. So like I mentioned in the previous slide, nurse cells are found in each of those seminiferous tubules. So some things they do. They maintain the blood-testis barrier, and that's a way to protect sperm from certain items in the blood that you do not want entering into these parts of the testes. They support cell division, both mitosis and meiosis, and spermiogenesis, outfitting them with a flagellum, making them motile, meaning able to move. And then also, nurse cells are secreting a few different chemicals. Inhibin is a hormone that can inhibit, the name says it all, it can inhibit sperm production. And so as sperm production rises in terms of how many sperm are made, inhibin will be released more and more and more as a way to keep it in check. You don't want too many sperm being produced. You want just the right amount. The next one, ABP, stands for androgen binding protein. So if you remember from the hormone lessons, androgens are typically male sex hormones. So androgen binding protein from nurse cells actually makes it more likely that androgens, male sex hormones, are going to hang out in the seminiferous tubules, and that helps encourage healthy, normal sperm production. And MIF, this is something that actually prevents a male from becoming female in utero. So even in utero, you have action within the gonads to make a male. And MIF will prevent the development of a uterus and uterine tubes. And it turns out that if MIF is not secreted if enough of it is not secreted inside a developing baby in utero, that baby is more likely to not get the descent of the gonads down the gubernaculum, and they'll stay up inside of the abdomen and not be born with that healthy, normal look that a male baby would have. So what is a sperm made of, if we look at it? Let's start with the front part. The head is where the nucleus, that important nucleus, is held. So the head has a nucleus just like any other cell of the body, except the nucleus of a sperm should have half the number of chromosomes, 23. And it turns out that sperm are going to have as its sex chromosome either a Y or an X. So what's inside of this, X or Y? Well, about half of the sperm have an X and half have a Y. The reason why is a healthy normal male has X and Y as his sex chromosomes, I misspoke. And when meiosis happens, half of the sperm are going to get the X, half are going to get the Y. So sperm is what determines the sex of the baby. Eggs are always supposed to have an X sex chromosome. But sometimes errors happen with that. I'll discuss more about that in the development lessons in terms of embryology. But in front of the nucleus, you can see it's kind of in a yellowish green color, wrapping around the front of the nucleus. And that's most of what the head of the sperm is a nucleus in that head. But the front of it is the acrosome, or sometimes it's called an acrosomal sac. And the acrosome surrounding the head has enzymes that are great at dissolving the barrier to the outside of the egg, the ovum that the sperm wants to fertilize, that outside part called the zona pellucida. The acrosome, once the head makes contact with it, it helps the head dig its way in there and eventually fertilize the egg. The neck of the sperm, very tiny part, but that's where you're going to get centrioles. And they're in yellow here. If you've taken biology, you know that centrioles are those kind of like anchors for microtubules that are going to be pulling on chromosomes. So the centrioles there are left over from when this sperm was made, in addition to other sperm, through the process of meiosis. So the neck, very tiny portion, and you're going to find centrioles in there. Perhaps just one. That's why here they say centriole. Mid-piece. Let's do that in red. Middle piece is another name you're going to come across, but the mid-piece or middle piece right here, massive amounts of mitochondria. That's what you're finding all throughout here. And why are mitochondria needed? Quite simply, the sperm has a long journey, and it needs to be moving that flagellum to get there, to get to its destination in the fallopian tubes. That requires a lot of energy, and if you remember from biology, mitochondria make ATP. That is an energy molecule that will power the flagellum and make it, do its motions. It's not like this, like a cilium. It's more of a twisty-turny kind of corkscrew motion, and without mitochondria here, you're not going to get the power to that flagellum. And yes, the tail, one of the most classic parts of a sperm that people are familiar with is that flagellum. And this is the only cell in the human body, only normal cell in the human body, that is outfitted with a flagellum. You would not find flagella in the female body unless she's recently had sex and they're from a male. The path of sperm. So if we kind of review what we've talked about so far and a sneak preview of what's coming up, a testis or a testicle is where they're made and where they begin. They end up in the epididymis. So I'm going to highlight some of these for you. The epididymis right here. And then from the epididymis, they're going to end up in the vas deferens. I'm actually going to use yellow for this. This is also called the ductus deferens. Here, they use the word vas deferens. I tend to use vas deferens instead of ductus deferens because the term vasectomy, which you're going to hear more about later in the lesson, is when surgically the vas deferens is clipped. But here's the vas deferens in yellow. Actually, that yellow is hard to see. Let's do it in green. So here it is. It goes out of the scrotal sac, inside the abdomen, all the way to here. And then you're going to get little accessory glands on the way to the urethra. So keep in mind that this is the bladder, here's the urethra, and you're actually going to get the vas deferens or ductus deferens going all the way to here. And then once it comes into contact with the urethra, that's effectively the end of it. But associated with that ductus deferens or vas deferens, you've got several accessory glands. So first, the seminal vesicles. Seminal vesicles. Here's the first kind of gland that is a major contributor to semen. So the seminal vesicle adds some fluid to that passageway. The prostate gland also is going to add some fluid. So the prostate gland is actually surrounding the urethra. You can see it's just inferior to the bladder. The ductus deferens goes through it, and then it adds some fluids to form more of semen. The prostate gland is kind of has the look of a chestnut. And then in purple is the bulbourethral glands, also called Cowper's glands. You can see right here. There actually are two near the base of the penis, and you can see that they're that last little set of contributors to what's going to end up in the urethra and coming out of the penis during sexual stimulation or intercourse. And then the urethra, yeah, that is the last passageway. Urine also goes out through it, but during sexual intercourse, urine's not going to be going out. It's going to be semen. So the vas deferens, also called ductus deferens, each one is about 40 to 45 centimeters long. It takes sperm from the epididymides, that's plural for epididymis. So the epididymides to the ejaculatory duct, which is right next to where the urethra is and kind of where it meets with the vas deferens portion. It runs adjacent to the bladder. We saw that in the previous slide, and passes by accessory glands, the seminal vesicles, the prostate gland, and the Cowper's gland. And in the vas deferens, you can see a thick layer of smooth muscles in the walls. That's what actually gets sperm out of the testes, all the way through this tract, and to receive those additional secretions from the glands. So peristalsis, we've seen this term come up a lot. It's those wave-like muscular contractions in the tube that encourages the movement of the sperm. And amazingly, the vas deferens can store sperm in it for several months. So it's more typical, of course, for sperm to be stored in the epididymis, but they can gradually creep up into the vas deferens. And that's why even after a vasectomy, when you cut the connection that takes sperm from the testes through that tube to meet eventually with the urethra, you can still have a chance of impregnating a woman, because even though you've prevented sperm from leaving the testes, you can have some sperm remaining in the vas deferens. So the doctor will tell you to wait a while before having unprotected sex. And I've heard stories of even like months after, even a year after having a vasectomy, it's possible to get a female pregnant. It's rare because the amount of sperm that are going to be hanging out in the vas deferens is a lot less than the amount that's released through the average ejaculation. But hey, all it takes is one sperm. Seminal vesicles. These are also called seminal glands. They're between the posterior part of the bladder and the rectum. They contribute about 60% of semen volume. So most of semen volume is thanks to the seminal vesicles. So you can see here's the vas deferens, and remember it goes through the prostate. Here's the urethra. So the prostate is the area where you're actually going to see the urethra and vas deferens connecting. The seminal vesicle right here is what's going to be actually contributing these items. So first, fructose. That's a sugar, and fructose is added to the mixture, which includes mostly sperm at this point, because it's like food for their journey. Sperm have those mitochondria, without being supplied sugars, they're not going to be able to make the ATP that powers their flagella. So fructose is like food for the journey. Prostaglandins actually help create muscular contractions in the male and in the female. Why the female? Well, after having sexual intercourse, it makes it more likely that the sperm are going to get to where they need to go if certain contractions are stimulated in the internal anatomy of the female reproductive system. So prostaglandins are little hormones that help do that. Fibrinogen, we saw that with the bloodstream. And fibrinogen is a chemical that with certain enzymes will be turned into fibrin, which remember can make a blood clot. Why is it here? Well, it will make a semen clot in the female. And it just further improves the chances of fertilizing the female. So fibrinogen will be turned into fibrin inside the female to make a semen clot. And then alkaline secretions. Alkaline means basic rather than acidic. Why alkaline secretions from the seminal vesicles? Because the inside of the female vagina is typically acidic. And that kind of environment could kill sperm. So alkaline secretions help neutralize the acidity inside the vagina and protect the sperm. And actually, the overall pH of semen is slightly basic. Prostate gland. It is a rounded organ that is about 4 centimeters in diameter. Like I mentioned earlier, it's about the size and look of a chestnut. It encircles the posterior portion of the urethra, and remember the vas deferens or ductus deferens comes into this area. You can see that right here, the ampulla of the ductus deferens on both sides. Here, the prostate in this image from Gray's Anatomy has been cut, so you can see where the urethra is. And here's the ejaculatory duct that's helping to expel semen through this region. It has glands inside of it that secrete fluid, and there's smooth muscles surrounding. So the smooth muscles in the prostate gland, their contractions actually help push those fluids into the urethra. And yes, it produces what's called prostatic fluid, and that's about 20 to 30% of semen. One of the particular chemicals inside of it is seminal plasmin, which actually makes it less likely that a male's going to get a UTI. It actually, studies have shown that this helps prevent urinary tract infections, has kind of like an antibiotic effect. And it's ever so slightly acidic, the prostatic fluid. But remember, like even though it's slightly acidic here, the alkalinity or the basic nature of what comes from the seminal vesicles has more of a contribution because semen as a whole is alkaline. The bulbourethral gland, there's actually 2 of them, bulbourethral glands, also called Cowper's glands. You'll see some textbooks use the term Cowper's glands, named after a Dr. Cowper. So this pair is located at the base of the penis, near the crus of the penis. After you go through those other accessory glands, this is the last additive added to the semen. Diameter of less than 10 millimeters, very tiny, and they secrete a thick, alkaline, once again, basic mucus. This helps neutralize urinary acids because urine, typically acidic, and you want to make sure that the urine left over in the urethra does not have a harmful effect on the sperm that are going to be traveling through that same passageway. So it helps neutralize urinary acids, and it helps lubricate the gland's penis, helps lubricate the surface of that during sexual intercourse and prepare the penis to receive semen going through it. So semen, what is in it? Well, typical ejaculate is about 2 to 5 millimeters. Of course, that varies from different males having different amounts of ejaculate. But what's inside of it? It contains, of course, sperm. You can also call them spermatozoa. Hundreds of millions are typical in the average semen ejaculation. They say that there's about 100 million per milliliter. So that's why you'll hear that there's about 300 to 400 million inside the average ejaculate, because if this is the average amount released, let's say a man releases 3.5 milliliters, you can approximate and say that that's about 350 million sperm. Seminal fluid, that's the rest of the stuff that was added from those different accessory glands, seminal vesicles, prostate gland, Cowper's gland, and enzymes. many functions with these enzymes. One of these enzymes actually converts fibrinogen into fibrin to make that seminal clot. And these enzymes also can help protect sperm on the way by keeping bacteria from affecting them negatively. So male reproductive conditions and disorders, impotence. Impotence is the inability to maintain an erection. Low sperm count is sometimes associated with that, but they're not always associated together. So impotence, inability to maintain an erection, and of course, certain medications can help with that. Low sperm count. There are various reasons why this could happen. It could be trauma. It could be certain drugs. It could be malnutrition. There's a lot of reasons why low sperm count can happen, and your doctor can tell you more about that. But low sperm count, it might not be as low as you might be thinking. Because remember, from the average ejaculate, you're talking hundreds of millions of sperm. Somebody who's releasing, let's say, a couple 100,000 sperm, that's a low sperm count. Not even a million. And that still sounds like a lot, but as they go through the female reproductive tract, a lot of those sperm are going to get swallowed up by white blood cells. They have a long journey. They can get damaged. They can end up going where they're not supposed to be going. There's lots of reasons that sperm fail on their way to try to find the egg. But if you have a sperm count that's in the tens of thousands or hundreds of thousands, that's considered low. And depending on how low it is, they'll consider the man infertile. But it's still not impossible for them to have a child, because remember, it only takes just one to fertilize an egg, but the chances of that one making it when your count is that low, it's just very low likelihood. Erectile dysfunction is associated with being impotent, but erectile dysfunction is a little bit different, because you'll have men who had no problems maintaining an erection early on in life, and then typically as you get older, it's more likely that a man is going to experience ED or erectile dysfunction. And there are lots of reasons for that. Some of it is the drop in testosterone from the testes that can relate to it. Stress, an enlarged prostate gland can actually negatively impact the ability to maintain an erection or get an erection. A priapism is a prolonged erection that lasts more than 6 hours. That's not normal. And there's lots of reasons why a priapism could happen. One of them is actually spinal cord damage. Getting a severe injury to the spinal cord can create a lot of vasodilation that would be associated with priapism. And you have to go to emergency room to get this taken care of, because having excessive blood flow in the penis for that long can have negative long-term consequences. But that's how an erection happens. It is vasodilation, getting a lot more blood flow in that region. That's what makes the penis stiff. Benign prostatic hypertrophy is a fancy term for saying like the prostate is getting enlarged, and it's normal, fairly normal in men over the age of 50 to get a slightly enlarged prostate. The effects of getting older, and it's similar to what I was mentioning with ED, drop in testosterone, certain dietary factors can have a lot to do with it. Blood pressure can have a lot to do with it, but this is a gradual enlargement of the prostate. And there are lots of medical procedures where they can go in through the urethra and remove some of that tissue to help with this particular condition. If it gets to be too much, if it's too much of a growth, and you actually have what they would call malignant tumors inside of there, rather than benign means it's not growing rapidly, but malignancy inside of it will actually result in probably getting a prostatectomy. That's a removal of the prostate gland, and that would be to prevent something like prostate cancer from spreading. The success of a prostate removal, it depends on how early you catch it. Somebody who has had the cancer developing inside their prostate for a while, if it moves into the lymphatic tissue and the cancer spreads into other parts of the body, the vital organs, the likelihood of survival is going to be a lot lower. But prostate cancer is one of those cancers that impacts a lot of elderly men. STDs, of course, there's a lot of them. I mentioned them with the female reproductive system. There's bacterial ones, there's viral ones. Some of them have cures, others don't. Like the herpes virus is not curable, but there are medications that can lower the amount of outbreaks you get on a yearly basis. An orchiectomy is removal of the testes. So it's not normal to remove testes from men, but this would have to happen if, like I mentioned earlier, if the gonads don't descend down the gubernaculum in a baby who's developing in utero, they would have to remove them so that they don't become cancerous eventually. And a vasectomy is what a man will do to get fixed. So unlike with dogs or other animals where they just remove the testes, that would be cruel to a man because you get male sex hormones from the testes. You want to maintain an active, healthy sex life if you're a man. But if you don't want to have kids, a vasectomy is where it's an outpatient procedure. They don't need to put the man under full anesthesia. It could take 20 to 30 minutes to do. They would inject a local anesthetic, meaning going into the scrotal region and injecting numbing substances. And then they'll go in, cut through the scrotum, and then snip through the vas deferens. That's why it's called a vasectomy, or the ductus deferens. And they snip through it, they'll cauterize the ends, which prevents sperm from going through the vas deferens all the way into the urethra. So a man will still produce sperm as they normally would, but the sperm have nowhere to go. They'll keep getting produced, and they'll die, and they'll recycle the parts. And a man can maintain a normal sex life because the percentage that sperm are in semen is quite low. I've heard 10% or less of semen is actually sperm. So they'll still have a normal ejaculate, but you're less likely to impregnate a person when you get a vasectomy. So thanks for watching Educator.com.